So I'm serving ketamine. I have a wait list of about 5,000 people that want to see me for functional medicine, but this is the work that I want to do. So I'm looking for people who want to do this work. Once MDMA becomes FDA approved, then we'll be able to offer that MDMA-assisted treatment. And for people who've got psychiatric diagnoses, I think it's better to work with a psychiatrist or with a therapist who's well-trained and trauma-informed. But for people that I work with who are more, have some traumatic experience, want to address some of the functional medicine issues that they have, that's a good fit for me. So in Oakland, California, psilocybin is decriminalized, but really it's only in Oregon right now where psilocybin-assisted therapy is considered legal. And then there's also in Colorado that's coming. So, this is a landscape that changes pretty quickly. Mm-hmm. But right now, the only thing that I can do above board is ketamine.
Dr. Sara Gottfried is a physician, researcher, author, and educator. She graduated from Harvard Medical School and MIT and completed her residency at UCSF. But she is more likely to prescribe a personalized nutrition plan than the latest pharmaceutical. She's also a clinical professor in the Department of Integrative Medicine and Nutrition Science at Thomas Jefferson University and the Director of Precision Medicine at the Marcus Institute of Integrative Health. Dr. Gottfried is also a global keynote speaker and author of 4 New York Times best-selling books about hormones, nutrition, and health. Her latest book is called The Autoimmune Cure. I am so excited to have you with us today, Dr. Gottfried. Welcome. Welcome to Take Back Your Health with Dr. Amy Myers. I am thrilled to have you here, a fellow woman, colleague, functional medicine, and physician who is focusing now somewhat on autoimmunity. So super excited to have you here, a sister from another mother, I guess.
Delighted to be with you.
For those that are not familiar with you, you are trained as a conventional physician like myself and then got into functional medicine. Do you want to first kind of just share your background and that journey of how you got to where you are today?
I started in obstetrics and gynecology. I felt like that was the area where I could help women the most. I learned a lot in medical school and residency about this massive gap that women were facing in terms of their health. And Dr. Myers, I feel like that gap has just worsened since 30 years ago when I went through my training. And it was when I was in my mid-30s that I realized that the conventional medical system fails so many of us. And the way I confronted that was that I was in my mid-30s, I had 1 kid, and I just couldn't lose the weight after having a baby. I had PMS. I didn't want to have sex with my husband. I was just really struggling. And I went to my primary care doctor who did the best he could. He offered Prozac and a birth control pill and told me to exercise more and eat less. So that was that moment where I was just like, okay, if I'm being told this and I'm a physician, so many millions of women are being told this, and it's just not right. So that galvanized me to turn left. I had been listening to Jeff Bland for about the decade before, and I had always been integrative, and I just went deeper into that work.
I experienced something similar myself when I got diagnosed with Graves' disease. I was in medical school and went to my primary care physician, and she just brushed me off and said, "Oh, it's medical school stress. You're just learning about all these diseases and now you think you have one." And again, it was like I was very persistent, and I was just having this conversation with another woman last night, about particularly we women, getting so brushed off, right? And that so many of these symptoms that we'll dive into with autoimmunity, with hormone imbalance, are actually these real things, but they get brushed off as, oh, postpartum, you just had a baby, of course you're tired. Or, how many of us have been told, oh, just eat less, exercise more, right? And brushed off, or offered these drugs to potentially treat a symptom, but certainly not get down to the root and figure out what's going on.
I think it's worse than getting brushed off, because when you look at the history of women's experience and the kind of symptoms that they describe to their physicians, there's a way that they're gaslit. There's a way that they're told they're just getting older. And it leads to a woman either accepting that and feeling somewhat disempowered, or it leads to someone like you and me saying, okay, I'm not going to stand for this. There has to be a different way. And I'm so glad that you and I both started to seek that root cause, because I really feel like that makes all the difference in terms of identifying the levers when it comes to chronic disease and then changing those levers.
As you mentioned, much of your focus really has been on hormones, and you've written a number of New York Times best-selling books about hormones and, being younger. And now your latest book, The Autoimmune Cure, you've moved into the autoimmune realm. So first, do you want to kind of tell us about that shift and what sparked that? And then, I love that so much of the book is about trauma. So I definitely want to dive in there.
Yeah, there were a few things that led to this particular book. One was just realizing that hormones are an important portal to learn about your body, but they're not the whole story. I think of them like text messages in the body. But when you look at some of the triggers that we experience, triggers that we think about in functional medicine, we know that, one of the triggers could be the pandemic, getting exposed to COVID. Another trigger could be trauma, adverse childhood experiences. And when we look at triggers, the systems of the body that they affect the most are the PINE network. So PINE is the psychology. That's the P. I is the immune system, which you've done so much beautiful work with, and is the neurological system, which can become dysregulated with these triggers. And then E is the endocrine system. So I think thinking of this network, the PINE network, is an important way to consider chronic stress, toxic stress, and the ways that it becomes embedded in your network. And then on the patient care side, what I noticed is that I had so many women with autoimmunity that were coming to see me during the pandemic, post-pandemic. And I was seeing this exponential rise because I test everyone for autoimmunity. I was seeing this epidemic rise in anti-nuclear antibodies, in the antibodies associated with autoimmune thyroiditis. And we're starting to see the literature catch up to this. So that got me really curious about it, as well as wanting to look at root causes. And as I started to ask my patients more about toxic stress and trauma, I found that about 80% of the women with autoimmunity, men too, had trauma. So that got me to kind of connect the dots and to start to look at what's going on in our world right now, because we've got, right now about 5% of the global population has autoimmune disease, as you well know.
And that's just that we know about, right? I mean, the number of people with antibodies, that nobody's tested or uncovered.
I was talking to our friend Mark Hyman recently about his lab that he now offers, doing functional medicine testing twice a year. And in this cohort of 100,000 people like you and me, relatively healthy, we know that 30% of this 100,000 people have anti-nuclear antibodies. And so I test myself. I found that I became positive for anti-nuclear antibodies about 5 years ago. And I often find that the things that are happening in my system are a reflection of what's happening in our culture. And so that's what got me to pay attention to it and to start to write about it.
For those that are not familiar, I mean, an ANA, which is what it's called, is a regular routine lab test. Now, I'm sure you do some more sophisticated testing. When I was in practice, I had a panel that the lab company that I used would run, and it checked an ANA, it checked thyroid antibodies, it checked for Sjogren's, it checked for, some various other autoimmune conditions. And so, these labs, an ANA and probably even a TPO for thyroid antibodies, to me, should just be standard of care. Particularly for women going to the OBGYN, they are generally checking basic labs on, most people checking for anemia, things like that. I mean, these are so easy to add in and, really, frankly, not expensive tests. And should be covered by insurance because we know that many of these antibodies come out so many more years, 5 to 10 years before people even get diagnosed. And I know, from functional medicine, I mean, there's so many things that we can do to reverse these so that someone who's presenting with antibodies many years ahead never actually ends up with autoimmunity.
And that's really the goal, that we are able to do this root cause analysis and to intervene before someone starts to lose function. I mean, that's really the principle of functional medicine, as I know you know so well. And in my mind, the earlier that you intervene, the better.
Mm-hmm.
What makes me so sad is that the current state of affairs is that even though somewhere around 1 in 3 of us has positive anti-nuclear antibodies, or 13% of us have antibodies against the thyroid, what we know is that these folks with autoimmune disease or pre-autoimmunity often are seeing 4 to 6 physicians before they're correctly diagnosed. And they're suffering, as you described, for 5, 10, 12 years before they get a diagnosis for these somewhat mysterious symptoms. And it affects 4 times more women than men. So that whole issue of being dismissed, of being gaslit, is a big part of this conversation.
It's all over the news right now. Celine Dion, with her stiff person syndrome, and she has a documentary coming out, and there's just lots of interviews. And I was reading one that I think it's the last 15 years she's been suffering on and off, right? And then you're just so relieved that someone actually gives you a diagnosis, even though, it may be a devastating one. At least someone's finally given you an answer. But I mean, if you think back, over those 15 years, what could have been done to potentially prevent her from ever actually, getting this diagnosis, which also, I mean, we could go on and on, I'm sure, in these articles is talking about the drugs she's doing and the various things. And I, of course, didn't read anything about, diet or lifestyle changes. So that, of course, for someone like me and you is, of course, sad to read as well.
Yeah, I feel like we should give a shout out to Celine Dion right now because she's such an icon. She's got people who love her work, love her music, love her singing. And I just wish that people who have a large platform, who have autoimmune disease, would talk more about this. But there's still a lack of awareness. When we look at the people who go to see a functional medicine clinician who understand about root cause medicine, who understand about the systems approach to the way that you take care of the body, mind, and spirit, we haven't penetrated enough of the celebrities. We need to get more of them on board so that they can talk about this and help more people, because I just feel like autoimmunity is something that the government does not track very carefully. And yet when you look at the studies, like the rate of anti-nuclear antibodies over the past few decades, the rates are increasing exponentially, as you know. And we've got to turn the ship around. And I feel like the way that you do that is with functional medicine.
Absolutely. I mean, conventional medicine doesn't offer a solution. It offers drugs that shut down your immune system, potentially, help with symptoms, but it's never looking to find the root cause or solve the actual problem. Well, let's dive into trauma, because that is something that, I don't really talk about in my books, and you spend a lot of time. And it's so true. I mean, looking back on my own life, my diagnosis came out right after my mother had passed away, after a very quick, brief 4-month battle of pancreatic cancer. And then, within that year, I started having my symptoms of Graves' disease. And certainly had many childhood, well, not many, but had, divorce and childhood traumas. So you talk about the ACE score. Do you want to explain what that is to people, how it's calculated, and maybe even give some of the top traumas
Yes. So the adverse childhood experiences score is one of the best, most validated measures that we have to look at your load of trauma. And so my score is 6. I'll just give a quick punchline here. So I had divorced parents. I had some other issues that this particular questionnaire looks at. And we've got a questionnaire online for, maybe we can put it in the show notes if people want to figure out what a score is. So adverse childhood experiences was initially part of a study that was performed by the Centers for Disease Control and Kaiser Permanente in San Diego. So they looked at this population that was insured by Kaiser Permanente, mostly middle-class folks, and they looked at them in middle age. So these people were adults, and then they looked at, what was your childhood experience? Did you have any of these adverse experiences before age 18? And they were things like neglect, physical abuse, emotional abuse, sexual abuse, much more common in women than men. Having a parent who had a substance use disorder, having someone in the family who went to jail. So there was a total of about 10 different questions. And so this is one of those tests that you want the lowest possible score on, ideally 0. But we know that about 60 to 70% of us have adverse childhood experiences. And it's about 10% more common in women, young girls, than it is in men. So this sets us up for some of the sex differences and also potentially maps to the increased vulnerability that we see in women compared to men with autoimmunity. And I'll back up for a minute because I know you probably also follow Alessio Fasano, the pediatric gastroenterologist at Massachusetts General Hospital, who taught me many decades ago about this connection, a 3-legged stool that you need for autoimmunity, genetic predisposition, increased intestinal permeability, so-called leaky gut, and then a trigger. And so those triggers are where things get interesting because you have the power to address those and to address the way that they affect your body and maybe your risk of autoimmunity. So that could be adverse childhood experiences. It could be a trauma that you experience as an adult. I feel like very few of us survive until middle age without some sort of trauma that we've been exposed to. But it can also be perimenopause. It can be pregnancy and the postpartum period. It can be these big hormonal shifts that women go through. And it can be infection. There's lots of different triggers that people can experience. But out of that 3-legged stool, it's the leaky gut and the triggers that we can do the most about. So as I started to look at this and I started to ask my patients more rigorously about their experience of trauma and how that lives on in their body, I found that about 90% of the patients that I was seeing with autoimmune conditions or with autoimmunity before a disease was diagnosed had a significant experience of trauma. So that's what got me to start to look at these things. And then I had this positive anti-nuclear antibody myself. I had pre-autoimmunity and I had an A score of 6. So that got me to start to look at, okay, how do we resolve that signature of trauma in the body? How do we work with that as a particular trigger? And that's what got me interested in looking at trauma-informed therapy, looking at the gold standard that we have for dealing with trauma, which, Amy, frankly, is not very effective. If I was told in my 20s, when I started talk therapy to work on my trauma, that the efficacy was about 30% of being able to resolve my trauma with weekly therapy, at a significant expense, I don't know that I would have done it.
Because you discuss it, but, there's Peter Levine and his work actually advocates not to do talk therapy because you are reliving the trauma. And I've mentioned this story on a podcast previously, but I'll quickly mention it. I had a patient who was an interpreter. I can't remember what country in Africa. And it was mostly, women who had been sexually abused and a lot of trauma. And when you're an interpreter, she herself had, had this experience. And so she wanted to give back to her country. And as an interpreter, she would have to say, I this, I that. So she was now taking on all these other people's trauma. and she had vitiligo. And I said, honestly, I mean, I think you need to quit your job. But she got very frustrated with me, left, whatnot. And about a year later, wrote me back and said she finally had quit her job and her vitiligo had resolved. But can you imagine, you can't, as the interpreter, say they, you have to say I. So not only did she have her own trauma, she's now, if you believe in the power of that, of saying I and taking on these traumas, she was now taking on all these other people's trauma as well.
Yeah, she had vicarious trauma. Something that, there's a lot of professions that experience that. There's an interpreter, as you described. My sister is a teacher, and she has the vicarious trauma of working as a fourth grade teacher with kids who have so much trauma, people who cross the border or refugees. And there's a way that the problem with talk therapy is the re-experiencing of the trauma, but also the understanding of what happened is a different part of the brain. It's a different part of the body than the way that you resolve it. And those two different parts don't talk. So you would think that understanding your trauma better would help you resolve it, but it doesn't seem to, at least not most of the time. And yet, when you look at this 30% efficacy that we see with talk therapy for the resolution of trauma, and you look at, there's 3 different selective serotonin reuptake inhibitors that are FDA approved for post-traumatic stress disorder. Again, efficacy of about 30%. And then you compare it to some of the other treatments that we have, like psychedelic-assisted therapy. The efficacy there is double. So it's around 67 to 71% of people who go through 2 to 3 rounds of MDMA-assisted therapy, and they resolve their PTSD. So whenever I see something that's so much more effective than what conventional medicine has on offer and has as a gold standard, that gets me excited because it means that there's a big gap that needs to be addressed in a different way.
I definitely want to get into all the things that you write about, to resolve the trauma. Can we first start with, you have a quote in the book from, is it Gabor Mate, that says, trauma is not what happens to you, it's what happens inside of you as a result of trauma. I love that quote. So can you first tell us, what is happening, I guess, on a, cellular level, on a hormonal level, on an immune level, when we're dealing with this, trauma? And then I definitely want to get into, many of the, I would say some controversial ways of which we can overcome our traumas.
The quote from Gabor Mate is very meaningful to me. He's been a huge influence in the way that I think about trauma. And Bessel van der Kolk also talks about this particular issue that, people often differentiate between big T trauma and small t trauma, as an example. And big T trauma are the things that we would all agree were a traumatic event, a genocide, the Holocaust, surviving a near fatal car accident. Those are all big T traumas.
A pandemic.
And then there are these traumas that you might call small t traumas, maybe losing someone that you love prematurely, or, kind of the everyday slights that you might experience, things like bullying, or just getting into a disagreement or a conflict with someone that you really care about. And what we know, and what Gabor Mate is speaking to, is that it doesn't really matter whether it was a big T trauma or a small t trauma. The way that it lives on in your body, especially your pine network, is what we want to be concerned about. So for some people, their psychology is affected. So there's post-traumatic stress disorder, there's attention deficit disorder, which Gabor Mate writes about a lot related to trauma. There's disordered eating, very common for young women and young girls who have early childhood trauma. And that's something that I experienced. And got into food recovery, really not until my 40s. Then there's, the way that your psychology might be altered, such as with depression, anxiety. And then with your immune system, what I see, and I'm curious what you see here too, because it's so fun to innovate with you and have these conversations that I haven't seen documented before. I feel like for some of my patients, their immune system is the most vulnerable. Mm-hmm. They've got more resilience in terms of their psychology. They don't have post-traumatic stress disorder. Maybe they've got partial PTSD or subthreshold PTSD, but the system that's most affected is their immune system. Mm-hmm. So when you do testing like a lymphocyte map, or when you look at some of these other markers of immune dysregulation, they're positive. And you see this in folks. And then there are some people who've got their nervous system as more dysregulated as a result of trauma. And these are the examples of how trauma lives on. It's not so much what happened to you, it's the dysregulation that continues in your system. Mm-hmm. And that might be emotional dysregulation, but it can also be physiological dysregulation. And so many of the people who write about trauma, people like Peter Levine and Bessel van der Kolk and Gabor Mate, they tend to focus on the psychological aspects. Gabor Mate also talks about autoimmunity, but they don't pay as much attention to the physiological dysregulation, which is really what you and I specialize in. Mm-hmm. So nervous system dysregulation, one of the ways I track that in my clients is with heart rate variability. I think that's a great measure. And then with endocrine dysregulation, that's mostly the hypothalamic, pituitary, adrenal, thyroid, gonadal, gut axis, which can become so dysregulated when you get exposed to trauma. And I've had that, when I first tested my cortisol in my 30s, back when I went and saw my primary care doctor, my cortisol was 3 times what it should be.
You were an OBGYN.
Classic
on call.
Female doctor, total mess.
Right.
And it's not like that's an isolated thing, as you know, Amy. It's affecting so many different systems. It was contributing to my insulin resistance and make my cells numb to insulin. It was contributing to weight gain and belly fat. It was contributing to, wearing a continuous glucose monitor and seeing these high glucoses despite what I would eat. And so we want to be thinking about the Pine Network and how trauma might be living on, and how one part of that Pine Network might be even more sensitive than the others.
Yeah, and I think it depends on the trauma. I know for me, like I always say, one of the best things I did for my health was to get out of the ER. I would have a shift, that would start at 2 p.m, and maybe 2 days later I had a shift that started at 11 o'clock at night, and I went overnight. I mean, it was, to just not have a consistent sleep schedule really had, whacked out all of my hormones. And then I've had, toxic mold will, the first thing it does for me is elevate my ANA and then some other autoimmune markers. And that was one of the first clues, is I had some markers going up. And then I finally figured out it was toxic mold, got them all negative, then went to Mexico, had another exposure, and came back just a week in a place in Mexico, and my ANA had gone positive again. And then we built a house in Santa Fe, very sophisticated to never have mold, had lots of leaks. They didn't install the dryer vent per plans. 6 months in, that time I didn't have much exposure because I recognized it right away. But I then was diagnosed with PTSD because I had spent years of, ensuring that I was going to be safe, and suddenly I wasn't safe. So it wasn't about this actual exposure to the mold. It was about this mind, I don't want to say a bad word, that I didn't have anywhere safe to live and be. And I didn't know that, we were able to clean the house and I am safe now, but I didn't know that I was able to clean the house or not. And so it was months of this unknown that shifted into just primal fear. of PTSD. And in that case, and this will segue into what we can do for our traumas, I had tried EMDR for, after my mother's death, but it was, significantly delayed, as an adult about divorce and it really didn't work for me. And I'm just guessing that perhaps the trigger had been too far away, or I wasn't able to tap into it. I'm not sure, because I have a very powerful mind that, protects us, as many people do. But with this situation, I immediately went to EMDR, and it was so raw. I mean, I almost could start crying now of this traumatic event, and it was so real, and it was so right there happening that I was so easily able to tap into it, that the EMDR was very, very effective for me this time around. And so just kind of curious to segue into some of these other modalities that are more effective than talk therapy for traumatic events.
Well, thank you so much for sharing your story. You're incredibly resilient, and you know so much about toxic mold. So to share some of these experiences that you've had where you don't feel safe in your environment is so critical. And it's such an important invitation for our listeners, because, toxic mold certainly can make you not feel safe. I had that experience in a house that I had in Berkeley, and had to go through the remediation process, which is very costly and, kind of a difficult row to go down. And then I also had an experience in a relationship where I didn't feel safe. And so safety and the cues of safety are so critical. And a lot of us grew up in a household that was somewhat volatile, where we didn't learn secure attachment. We didn't learn safety. We didn't have a felt sense of, that touchstone of safety. And then we have to recreate it for ourselves. So you talked about EMDR, and it's so interesting. I feel like every time I talk to you, I get this kind of sister experience, because I also tried EMDR maybe about 15 years ago for some of my childhood trauma, and also some of the trauma of medical training, of which there is a lot. And I didn't find it that effective. And yet, this was related to my first book. I was reading about some of the things that can help you with cortisol dysregulation. And I really hoped that it would work, and it didn't work that well for me. And yet, so many people do have a good experience with it. And I love that you're kind of sandwiching this experience where EMDR did not work that well after your mother's death. Maybe it was a little too distant from it, and yet it was helpful with your PTSD. And a lot of people find that EMDR is incredibly helpful. It's one of those somatic treatments, of which there are many, that really help you kind of come back home to your body and create safety. So Peter Levine, whom you spoke about earlier, has a method called somatic experiencing. There's lots of different ways that you can create these healing states of consciousness that allow you to be fully embodied. For many of us, like with your experience with toxic mold, being embodied is not safe. So to be able to rewire yourself so that you have a sense of safety when you're in your body is really important. I mean, my experience growing up was that it was safer for me to go to my head. It was safer for me to do a little dissociation, kind of cognitive dissociation, something which is often lauded in medicine, to be able to kind of, in an emergency room or a crash C-section or a ruptured ectopic pregnancy, if you can dissociate and just kind of go into this mode of fixing, it can be very effective. And yet, in a relationship, in a marriage, as a parent, even, taking care of your own parents as they get older, that kind of dissociation doesn't help so much. So these somatic therapies, I think, can be so effective. You have an experience with EMDR. There's many others. I talk about the neuroemotional technique in my book. I also talk about Hakomi, which is a somatic mindfulness-based way of working with missing nourishment that I found very helpful personally, and then I trained in it. And then I also think that there's forms of breath work that can be really helpful, like holotropic breath work, which I did for the past 3 years while writing this book. And then, of course, the history of plant medicine and how it helps us kind of recapture the soul, the spirit that we might have lost as a result of trauma. I find that to be incredibly effective. Not everyone needs to do it or wants to do it, which I totally understand. But we're on the cusp of a revolution where we've got so many people with the experience of trauma trying things that are not working that well for them. And I feel from a public health standpoint that psychedelic therapy can really make a huge difference.
That's a broad term, I think, psychedelic therapies. So can we dive into specifically, what you're talking about? And, certainly, I don't know if we're talking ayahuasca, and in my experience, most people are leaving the country to maybe go be with a shaman, to maybe, doing Molly, and that's, there's certain states that's legalized in, other ones where it's not. I mean, let's kind of dive into all of that, if you don't mind.
Yeah, it's important to have an awareness of what the legal issues are where you live. So my experience, I've gone through 3 certifications in psychedelic medicine, mostly with 3 different medicines. And those are ketamine, MDMA, and psilocybin. Those are the ones that I have the most personal and professional experience with. I also have personal experience with ayahuasca, but I would say that ayahuasca is a more advanced medicine that I'm not prepared to serve. So when we look just at the literature on ketamine, MDMA, and psilocybin, often what happens is that the first way of trying to legalize some of these medicines, all of which are safer than alcohol, they're safer than riding a horse. The first step has been to get FDA approval of MDMA for post-traumatic stress disorder. So I mentioned some of the studies that have been done. So there's 2 phase 3 trials that have been published in Nature showing that for people who go through 2 to 3 treatments with MDMA-assisted therapy and a particular protocol that MAPS uses, the resolution of PTSD occurs in 67 to 71% of participants. And the first study was in mostly white folks with severe PTSD. The second study was in people with moderate to severe PTSD and a better racial mix. So we've got quite good literature looking at MDMA-assisted therapy. And Rick Doblin, the leader of MAPS, who has spearheaded this effort to get FDA approval for MDMA, really feels like trauma and PTSD is a sympathetic audience when we think, for instance, of our veterans who have a really high suicide rate, who have this experience of trauma, and they're not getting the treatment that they need in the VA system. We think that, something like MDMA-assisted therapy is a really great option for them. So more research needs to be done. We're still in this process of trying to get FDA approval for it. So ketamine is different. It's one of those medicines that I'm sure you used in the emergency room. I used to use it in the emergency room going back 30 years. We used a lot for cesarean sections and for children. And it's a dissociative anesthetic, but when you use it at lower doses, so about 1/10 of the dose that's used in anesthesia, it can have this range of outcomes. It can act like an empathogen, and it can also act like an entheogen, depending on dose. And so I use ketamine primarily with my clients. I work with a lot of executives and perimenopausal women. Those are the 2 populations that I tend to work the most with. And I use it for visioning. I use it for stuckness. Although the FDA-approved indication for using ketamine is treatment-resistant depression.
And you're using an oral form, I'm assuming, because there are ketamine clinics that you can go to and do IV ketamine. But with your patients, are you doing oral or?
Preference is to use it intramuscularly or
okay.
sublingual dose. The FDA approved treatment as ketamine is an intranasal form of ketamine. So with ketamine, I find that it's really versatile. It's legal kind of across the board in the United States. So it's a good place to start. And then some of these other treatments like MDMA and psilocybin, mostly what I recommend is using those in a research setting until we have FDA approval. And yet, there's randomized trials that are published in JAMA looking at a single dose of psilocybin for depression, showing that it's efficacious compared to placebo. There's a number of studies looking at things like substance use disorder and how effective psilocybin can be. Ketamine has also been studied in trauma. It's also been studied in disordered eating. So there's, every day there's new publications kind of expanding the way that we think about these as a way to augment therapy, to augment the therapeutic container.
I was asking my EMDR therapist the other day after reading your book, did she ever do ketamine with EMDR? And she does actually have a couple of patients that are doing, I believe they're doing the sublingual of ketamine, and then they do EMDR with her. And she says it's been, very effective. Now, I am a person who likes to be in control. And so, I don't drink much. I, don't do drugs. And so certainly the idea of ayahuasca has, scared me because the hallucinogenic effects. These three that you're referring to, though, my understanding is that they do not have any hallucinogenic effects. So can you walk us through either sort of your experience if you're doing this with a patient, or I know you write in the book, you've mentioned you've had your own personal experiences. Like, let's just take an MDA. Do you, is it a pill you're swallowing? How long did these effects last? I mean, can you just, I'm sure there are a lot of people that are curious of what is this experience really like? Where are you? Are you in a room alone? Is someone there as a guide?
Yeah, you're speaking to a couple things that are really critical to understand. The first is, I want to share with you that I'm someone who also likes control. And I felt like I never took any drugs at all until I turned 50. And never smoked pot, never took mushrooms in college. I've been kind of a hard driving type A. And so when I started to see the literature on MDMA after I turned 50, when I was looking at trauma in my own experience and also with my patients, and then had a conflict with a family member, I realized that, there's a time and a place for these medicines. And if I had the opportunity to resolve trauma and be a cleaner mirror for my children, be a better partner in my relationships, then I was going to do it. So you're right. Ayahuasca is a different medicine than some of these. But when you look at the mechanism of action, psilocybin has a similar mechanism of action in that it affects the serotonin 5-2A receptor. So there are hallucinations that it can occur with psilocybin, kind of depending on the dose. At microdoses, it's subperceptual, so you don't have the effect of visual changes and hallucinations, although it does seem to have an immune effect, and it works as an immune modulator. So walking you through what it's like to do these things, I've gone through about 12 MDMA-assisted therapy treatments with a psychologist about once a quarter over the past few years. And set and setting are really important. So set is your mindset, kind of the context in which you're thinking about and approaching the medicine and developing a relationship with the medicine. And then setting is your environment, which in functional medicine we know is so critical that feeling of safety, that feeling of having a container that really is supporting you. So MDMA is oral. You take a capsule. I am a big fan of ritualizing the process and making it sacred. So I typically go into the process with intentions, with, lighting sage and Palo Santo and, creating a container for healing and wholeness. And then I was very fortunate to find a psychologist who's a guide and developed a relationship with him over several years where he was helping me go back and re-experience some of these memories that I had of trauma as a kid and as an adult, and to complete the experience. Because one of the things that I think happens, especially for women, is that when you experience trauma, there's this idea that you go into fight or flight, right? From the research by Walter Cannon in the 1930s. But women tend not to go into fight or flight. They tend to go into freeze, fawn, sometimes faint, like a dysautonomia. And that was my experience too. I would freeze, I would dissociate, I would fawn or people please, especially in the relationship that I was in when I first started these treatments. And the problem with not going into fight or flight, but going into freeze, fawn, faint, is that you often kind of get stuck in terms of the stress pattern. You don't complete. And so that's why it lives on in the body and tends to trigger, in my case, my immune system, anti-nuclear antibodies, which, by the way, are negative now, similar to your story. And the thing about MDMA that I think is so unique is that it allows you to go back to these historical experiences and to have a much more neutral approach to them, and then to really feel the feelings that you felt in a way that you can process, and not from a place of understanding, but really feeling the feelings and grieving and feeling anger and outrage and, completing that process that you may not have ever completed as a kid or whenever you experienced the trauma. So that was my experience with MDMA.
And how long does that experience last? An hour, 3 hours, depends on the dose, depends on the person.
So with MDMA, the experience typically is 6 to 8 hours, depends on how you metabolize it. Ketamine's much shorter. It's typically somewhere around 60 to 75 minutes in duration, depending on the route of administration. And then psilocybin varies, also kind of in the 4 to 6 hour range. Some of the other medicines that I'm not trained to serve, like LSD, lasts longer. It's more like a 12-hour experience. And ayahuasca also can vary.
So you're trained in these methods. And you're located in California? Are these legalized in California? Are you serving patients and practicing with patients? Are you looking for patients?
So I'm serving ketamine. I have a wait list of about 5,000 people that want to see me for functional medicine, but this is the work that I want to do. So I'm looking for people who want to do this work. Once MDMA becomes FDA approved, then we'll be able to offer that MDMA-assisted treatment. And for people who've got psychiatric diagnoses, I think it's better to work with a psychiatrist or with a therapist who's well-trained and trauma-informed. But for people that I work with who are more, have some traumatic experience, want to address some of the functional medicine issues that they have, that's a good fit for me. So in Oakland, California, psilocybin is decriminalized, but really it's only in Oregon right now where psilocybin-assisted therapy is considered legal. And then there's also in Colorado that's coming. So, this is a landscape that changes pretty quickly. But right now, the only thing that I can do above board is ketamine.
Is ketamine, is it legalized in all? I mean, it's a legalized substance to begin with, but are there ketamine clinics in all states?
I don't know about all states. I mean, it feels like 20 years ago, there was a yoga studio on every street corner. Now it feels like there's a ketamine clinic on every street corner. So we have a lot of them here in California. But I also think you have to be careful about the medical model. I hear about people going to receive ketamine and they're left, in a gurney in a corner by themselves to experience ketamine. And I don't think that's the right way to do it. I think you want to do it either in a group process or with a guide that you really trust. I think set and setting is so critical. So we have to be careful not to over medicalize it. The way that I do it is to ritualize it and to create sacred space around it. And I think that's an important part of this process. It's an important part of healing.
If people are looking for a ketamine clinic, what types of questions would you recommend them ask to make sure that it's the right fit for them?
So I would make sure that the clinic has a lot of experience, that you have ideally a certified therapist who's with you during the ketamine process. There are certain forms of psychotherapy or somatic therapy that pair very well with ketamine, such as Hakomi, which I mentioned. Internal family systems also pairs really well with ketamine. So those tend to be the clinics that I recommend. The kind of clinics that have a really quick turnover and you're just in a room by yourself, I would ask about that and avoid it. And it's, the most important part of psychedelic-assisted therapy is the preparation, the trust, the set and setting, and then the integration. I think the integration is the most critical. So you want to have a guide. You want to have a clinician that you're working with who really understands how to do that well. Someone who's got life experience, someone who has a fair amount of experience working with these medicines. And you don't want to have a big experience with a medicine and then not integrate it, because it's the integration that allows you to change behavior and start to make some new neural pathways. We know that ketamine, for instance, increases neuroplasticity for somewhere around 72 to 96 hours after you take the ketamine. And so you want to take advantage of that time period to create these new neural pathways that support your healing and allow you to create a sense of wholeness. The other thing that I would look for is clinicians who have deep presence, who are able to hold space that allow you to feel utterly safe. So I think looking for that is critical.
And you mentioned, I think, some studies showing some pretty dramatic changes in 3 sessions. You've mentioned you've done about 12. Obviously, everyone's an individual. Their traumas are very different. But I mean, is there something that, a timeline anybody could even remotely expect that they, will they feel something different after the first one?
You feel different after the first one. So here we're talking mostly about MDMA. So with MDMA, what's interesting is that 2 to 3 treatments with the prep and the integration afterwards, using the MAPS protocol, that's been shown to have durable effects a year later. So this is very different from the psychiatric model of taking a dose of a medication every single day, like a selective serotonin reuptake inhibitor. We're talking about in the MAPS trials, the phase 3 trials, people went through these MDMA-assisted therapy sessions, typically 4 to 6 weeks apart. So inside of, about a 5 to 6 month period, people no longer met criteria for post-traumatic stress disorder. Their system was utterly changed. So that's the period of time that I think shows effectiveness. When you look at ketamine and you look at treatment-resistant depression, we know that ketamine has a shorter duration of action. It lasts for about a week. And so people who are getting treated for depression often need weekly therapy with ketamine for about a 6-week period. And then they notice a significant change. And I have lots of clients who find that their depression or anxiety gets better when they have the ketamine. And then starting around day 7 to 8, they start to increase their symptoms again. And what I like about that, when you apply a functional medicine model, is that she can work with some of these root causes along with helping the person feel better. And so it allows you to do this parallel process of psychedelic-assisted therapy together with functional medicine so that people are getting the best chance of relief.
If somebody did want to do MDMA sort of, under the radar, how does one ensure, other than I suppose trusting whoever is administering it, that you're getting a pure form and that there isn't, here in New Mexico, I'm hearing stories, virtually daily of people overdosing on fentanyl, that common street drugs are just laced with fentanyl because it's so cheap now. So, how is there a way to, what do I want to say? Where is the supply chain coming for people who are trying to do this good work, but it's not yet legalized. So where are they getting a form that they know is pure and safe?
This is where in the underground, it's buyers beware. I tend to recommend that people work above ground and pay attention to what is legal in their state, in their town. And in the absence of that, join a research protocol, because there's so many universities that are doing research on psychedelic-assisted therapy, Johns Hopkins, NYU, UCSF. So I would encourage people to join one of those research studies, and you just have to be really cautious about the underground system.
Right.
There's just not the same regulation. There's not the same accountability. There's not any licensure. So I think it's better to go with people who are certified above ground.
As we part ways, if you have time to answer 3 things that you recommend people can do today to take back their health, and then where everyone can find you and your books.
So 3 things to take back your health. I would say, as we think about this stool, this 3-legged stool of what is associated with autoimmunity, and you and I talked about our own stories of developing autoimmunity. I would say, number 1, know your genetics, know your genetic blueprint so that you understand how to work around it. And then number 2, if you have increased intestinal permeability, which is something I see in most of my patients, do something about it. Take L-glutamine, take aloe, do an elimination diet, which has been shown to help with leaky gut. And then number 3, really assess yourself, do an inventory of triggers. And if you've got trauma, you want to address it. Start with an ACE score. Find out what your ACE score is, because that's so critical for your health in middle age. And then to learn more about me, the best place to go is saragottfriedmd.com. And I hang out mostly on Instagram at saragottfriedmd.
And her latest book is The Autoimmune Cure, if you would like to find out more about what we were talking about today. Well, thank you so much for being with us today, and I'll let you run to your next appointment, but great to catch up.
So good to catch up. Looking forward to the next time.
I want to thank this week's guests for sharing their time and knowledge, and thank you for listening. To read the full show notes for each episode, which include a summary, timestamp, quotes, and any resources mentioned, please visit amymyersmd.com/podcast. Lastly, if you've enjoyed this episode, I'd love if you would leave a rating and a review on Apple or Spotify, and we'll select a few to read out loud in a future episode. Tune in next week to hear from another inspiring guest as we help you take back your health.